Xtalks is the industry leader in connecting life science, food, healthcare, and medical device professionals. The Xtalks Life Science podcast features insightful conversations with industry experts about all things pharma, biotech, and more.
Hello and welcome to the Xtalks Life Science Podcast. I'm Ayesha, Senior Life Science Journalist at Xtalks.com. And this week, I'm very happy and delighted to introduce two very special guests on the show. We have with us today Dr. Suzanne Schindler, who is the Associate Professor of Neurology at Washington University, specializing in the diagnosis of dementia. We also have with us Dr. Alessio Travaglia, a neuroscientist and Director Neuroscience at the Foundation for the National Institutes of Health, or the FNIH. So a recent study led by the FNIH Biomarkers Consortium and with data analysis led by Dr. Schindler has found that some commercial diagnostic blood tests are accurate enough for clinical use and could replace cerebrospinal fluid, or CSF, or spinal taps and PET scans in the near future for the diagnosis of Alzheimer's disease. This would, of course, save patients from the cost and pain associated with traditional diagnostic approaches. The findings could improve clinical diagnosis and speed future drug development by helping researchers select optimal clinical trial participants, for example. The findings of the study were presented at the Alzheimer's Association International Conference, or AAIC, in Philadelphia recently. And we're so happy to have the leads on that study with us on the podcast today to hear firsthand from them. So to learn more about these biomarker tests and the study, let's turn to Dr. Schindler and Dr. Travaglia right now. Thank you so much to the both of you for being on the show today.
Thanks for having us.
Thanks for having us.
I'd like to start off by first kind of setting the stage and really understanding what the current unmet needs in Alzheimer's disease are, specifically with respect to diagnosis. So I'd really love to hear your perspectives and input on that. Perhaps, Dr. Schindler, you can start by setting the stage for that.
So when a patient has problems with their memory and thinking, there are many potential causes. So one cause that people worry about is Alzheimer's disease, but there are actually many other disorders that could cause memory and thinking problems, things like poor sleep, problems with mood, medications. And so when patients come in to see a clinician like me, they're often wondering what's causing these issues. And in the past, we often did not do a comprehensive evaluation and do biomarker testing on many patients who were presenting with cognitive impairment. And actually, very few patients ever made it to see a dementia specialist like me. And as a result of that, many people who did have Alzheimer's disease as the cause of their cognitive impairment went undiagnosed. People often called it old age. And now that we have treatments that specifically target the brain pathology of Alzheimer's disease, it's become much more important to diagnose whether someone's cognitive impairment is due to Alzheimer's disease, and also to do this early, shortly after the onset of symptoms, at a time when these treatments are most effective.
Yeah, and I want to add that it's very interesting to put things into perspective and to look at the natural evolution of all this. Until a few years ago, we had diagnosis of Alzheimer due just to neuropsychological tests, basically a physician excluding other causes of dementia and making a diagnosis with a very high rate of false positive and false negative. And then a few years ago, we start having other procedures that could diagnose Alzheimer, starting with the PET scans, or positron emission tomography scan. This procedure is certainly golden rule, a golden standard for Alzheimer's disease, but A, it takes time, 2, is expensive, and also is not available everywhere. Same for CSF analysis, involves a lumbar puncture and so it takes time, resources, as it's not available everywhere. So it's very exciting. Now we're talking about a blood biomarker that is less invasive, more accurate, and accessible in many states and many centers.
So I'd like to speak more, of course, about the FNIH's latest study about the use of biomarker-based blood tests and really their significance for the diagnosis of Alzheimer's disease. So very exciting findings looking at, it was a head-to-head study looking at how these tests compare to traditional testing for Alzheimer's. So I'd love to hear more about this study from the both of you and what the study has shown.
Sure. Let me start with that. And let me actually take a step back. Mentioned before, I'm personally very excited about this natural evolution and now having and talking about blood tests for Alzheimer's disease. But there is a huge range in this test. Some are accurate, some are not or less. Some are clinically available or commercially available. Others are in the validation stage. So, in other words, there is a limitation in the widespread use of this blood biomarker for Alzheimer's disease. And at the end of the day, physicians must know which test they can trust. Because of that, the FNIH, or Foundation for the National Institutes of Health, developed and launched this head-to-head study to examine and comparing blood tests for Alzheimer's disease and which of these tests or tests can accurately analyze and detect amyloid plaques in the brain. I also want to say that the FNIH is a non-profit organization independent by the NIH. So what we do is really convening stakeholders from academia and industry, design a run project to solve problems that no single organization can do on its own. And so the study and the analysis of the data were led by Dr. Suzanne Schindler here, compared the accuracy of leading commercial blood tests for Alzheimer's disease. And I'll actually turn it over to Suzanne to tell you more about the result per se.
So the FNIH Biomarker Consortium started by identifying some of the leading tests for Alzheimer's disease. 4 of the tests that were identified are actually clinically available. A physician can order them. 2 of them are not yet clinically available, but they're being relatively widely used in research settings and are expected to become clinically available. We, of course, looked at other tests as well, but for various reasons decided that they did not kind of fit into the study. We ran the same samples from the same individuals on all of these biomarker platforms. And this is actually really important because previous studies had tested these different assays in different groups of people. And it turns out that if you're looking at different groups of people, that the tests can have different performance. So it's really an apples to oranges kind of comparison. So the way that this was designed, we could really do a head-to-head, apples-to-apples kind of comparison and really see whether these tests perform the same way or if they had significant differences. And what we found is that some tests perform much better than others. And we also saw a very consistent finding, which is this one particular test for something called p-tau217 performed very well across 4 different companies, assays, and in individuals who had cognitive impairment, they were around 90% accurate or even more accurate in determining whether an individual had amyloid pathology or not. And that 90% number is important because that's about the accuracy that we see with currently FDA approved and clinically used CSF tests. So what this means is that those tests for p-tau217 in the blood really can be used in patients to determine whether they have amyloid pathology, whether that may be contributing to their cognitive impairment.
And so from what I understand is that the study points to the fact that these tests could potentially be used on their own, because I know leading up to this, we've heard a lot about about biomarker-based blood testing, but I think the caveat was always that they couldn't be used on their own and they would have to be used in combination with other tests or to be followed up or confirmed by other tests. So would that be the case that these tests could be, in actuality, be used on their own? And what makes them, what sets them apart from, let's say, previous tests that had those caveats to them?
So I think that for some of these tests, they are performing just as accurately as FDA-approved CSF tests. And so it seems a little silly to me as a clinician to follow up a blood test with another test that's similar level of accuracy. There may be some scenarios where you might want to do that. So for example, we know that blood tests are not as well validated in individuals who have certain medical conditions, for example, chronic kidney disease, or for example, individuals in some minoritized groups. So in those individuals, there's a higher level of uncertainty about how these blood tests will perform. However, if you have a very clear-cut positive result in these blood tests in someone who doesn't have those kind of issues, and someone who looks like the population in which these blood tests have been validated, then I'm not sure that there's as strong of a rationale to need to follow these up with a second test. One other caveat is some of these tests have already been studied in a number of different cohorts. So there's quite a bit of validation data and also data demonstrating that they perform similarly over time. Some of these other tests have not been as well validated, and something that we worry a lot about with tests is that sometimes we see what's called assay drift, where the values can shift a little bit over time. So I think that for some of these assays, we'd like to see additional data. We'd very much like to see additional data on how these tests perform in different types of populations. But some of these tests really are performing quite well.
Yeah, I totally agree. And there is no value in doing a blood test after or before like another test. The goal is to have just one single test. Patient goes to the doctor, you draw the blood, you do the analysis, and you're able to understand how the patient is doing. Something though that we can clarify is the stage of disease the patients have, because right now we have to have people that are cognitively impaired, and we are not able yet to detect people that are cognitively unimpaired. And so the next step is to develop a biosignature that is able to detect people before they have symptoms, and we're able then to monitor their disease progression.
And so that was going to be actually my next question with respect to what stage of disease are these tests best suited to detect. So, of course, early detection of Alzheimer's is an important area of research, a critical area of research. So how early can Alzheimer's be diagnosed with these tests?
So in clinical practice, we recommend that you only use these tests in individuals that are cognitively impaired. But sometimes people are coming in with very early symptoms. So these are individuals who have, for example, been functioning at a high level for many years, but now they're starting to notice that on a consistent basis that they're repeating questions, they're misplacing items quite frequently. So they've had a significant change from the past, but it's still pretty mild. So that sort of scenario is where these tests are very helpful, particularly because lots of things can cause mild memory problems. And many people go through periods of time where they have more cognitive lapses. So that's a scenario where these tests are most helpful. Of course, they can certainly diagnose the presence of amyloid pathology in people who are further along in the course of disease, although in some ways that may be less helpful. I would also note that these tests are very sensitive. So they're being used now in some clinical trials of cognitively unimpaired individuals to identify those at higher risk of developing dementia in the future. However, we see that their highest accuracy is in the cognitively impaired population at this point. And we can probably get better in terms of our ability to identify those who are at high risk for development of these symptoms. So the tests are quite good in cognitively impaired individuals for diagnosing whether they have amyloid pathology or not. They can detect people at higher risk, but they're not as definitive in terms of figuring out who's going to go on to develop dementia symptoms.
And I know you mentioned that the tests, one of the most prominent biomarkers was the p-tau217. Are there other biomarkers in the mix? I might have missed that, but...
So another one that's been studied quite a bit is the ratio of A-beta 42 to 40.
Mm-hmm.
And we found very interesting results for A-beta 42 to 40. It's actually not a very good biomarker in cognitively impaired individuals. And this is important because some companies are offering this as a test for cognitively impaired individuals, and it's just not very accurate in that population. However, we see that this biomarker, the ratio of A-beta 42 to 40, changes very early in the course of disease. And in people at very low levels of amyloid pathology, it has the highest correlations with the little bit of pathology that's there. So we think that A-beta 42 to 40, and in fact, also adding that, the combination with p-tau217 really is quite sensitive in detecting individuals who are at risk of developing symptoms. And that combination actually, A-beta 42 to 40 plus p-tau217 was the combination that was most strongly associated with amyloid pathology in the entire cohort, both cognitively impaired and cognitively normal. And that is the measure that's being used by some of these clinical prevention studies trying to identify individuals who are at risk for developing Alzheimer's disease.
Yeah, and Ayesha, you're right. In these years, we've been hearing a lot about the ratio 40 to 40, phosphorylation of tau in multiple residues, as well as the total tau ratio, as well as NFL, the neurofilament light chain, that is a marker of neurodegeneration in general, so not necessarily specific. And so, as I mentioned at the beginning, there's been a lot of confusion, and so it's been hard for physicians to know which test should they use in a clinical setting. So the beauty of this study is that now we have this comparison. We know that we have to have the p-tau217 in a biomarker for Alzheimer's disease.
And so what will the clinical flow look like for clinical use of these tests, and how will they really change the landscape of Alzheimer's diagnosis, in your opinion?
The major obstacle to using these tests in clinic right now is that they're not being reimbursed. So patients have to pay for them out of pocket. So for that reason, we have not been using them in many different patients. I think that will change, hopefully in the not too distant future. Once these tests are reimbursed, I think that we will be using them as the dominant method of biomarker testing in most of our patients. I think there will be a couple of exceptions. So one is if we do a test and we find that someone has a value that's kind of borderline indeterminate, then in those patients, I think we'll want to do follow-up testing, either with CSF or amyloid PET. Again, another scenario is when these tests are used in patients where there's been shown the blood test can be kind of confounded by other variables. So this is, for example, people who have chronic kidney disease or other issues, people taking certain medications. So there are some scenarios where we wouldn't want to just do the blood test, but I think for the vast majority of people, they could just do a blood test and that would be it. Of course, sometimes people come into our clinic and they have lots of other issues going on. And so depending on what those issues are, we still, for example, may want to do a spinal tap if we're worried about things like an autoimmune disease or some rare forms of neurodegenerative disorders. But again, that's a minority of patients, and I think the vast majority of patients in the future could just get a blood test, and that would be it. And that would really decrease the burden on memory clinics.
I totally agree. And the other beauty is these blood tests are scalable. And this means that also people are going to have access to these tests, including people living in rural area. You can imagine for these people how hard it is to get access to a PET scan or sometimes even a lumbar puncture, whereas a blood test is going to be available everywhere.
Yeah, those are all great points. The accessibility and cost, reimbursement, those are all real practical, real world considerations. And so really excited to see and hope that we're moving in the right direction within those aspects for sure. And in terms of, are there any specific patient populations? Because I know that with a lot of diseases, there's a lot of heterogeneity in terms of subsets of different patients. And so in your opinion, from your perspective, are there any specific subsets of patients, Alzheimer's patients, that will particularly benefit from these non-invasive tests over others? Of course, it's universally this will be game-changing indeed, but are there any specific populations that may have considerable benefit?
Well, as Alessio was mentioning, there are certain populations like individuals living in rural areas who may have more difficulty accessing the kinds of AD biomarker tests that we've had in the past. So I think those individuals will benefit. I also think a huge population has not been receiving any biomarker testing at all because they've never made it to see a specialist. And what blood tests mean is that a primary care provider could do a test for Alzheimer's disease. And in the past, primary care docs have not done spinal taps on their patients for Alzheimer's disease, and they certainly haven't been ordering amyloid PET scans. So that has meant that biomarker testing for Alzheimer's disease has almost exclusively occurred in these specialist settings. And what blood tests mean is that many more individuals can get a diagnosis. So it's actually a huge number of people who could potentially now get a more accurate diagnosis and also get a diagnosis earlier. Often the wait times to see a dementia specialist are many months to a year. And a lot of people, unfortunately, just even give up on that. So this really has massive implications for the diagnosis of dementia generally. So it's a huge number of people that may be affected.
I completely agree with Suzanne. And it's not necessarily the subset of patients that will benefit, but it's the patient experience that's going to change. It's the outcome that's going to change. As Suzanne mentioned, identify patients early is a game changer because these years we've been hearing a lot about how early detection means timely intervention, means giving a drug to a patient earlier, which increased tremendously the chance to be successful in a clinical trial. Also, if we want to look at the patient experience and caregiver experience, better testing, also, if we want to look at the patient and caregiver experience, better testing and earlier testing, it means that we are reducing the uncertainties that often comes together with the dementia diagnosis. So you can imagine how for a family it's already hard to hear you have Alzheimer's disease, but to know earlier is certainly better. And also we have been talking a lot in the field about personalized medicine. And in order to have a personalized treatment, we have to identify patients early. We need to tailor the treatment to this patient. We need to track disease progression as well as how the patient is doing with a specific drug. So because of all this reason, I think it's going to be a game changer. And so there is not a subset specifically, but it's changing overall the outcome for patients.
Makes sense. And that's a great point. Of course, Dr. Travaglia, that it'll across the board, it just means that more patients will have access to testing just in general. And Dr. Schindler, you also mentioned that it could be done at the primary care level, which I didn't think about, right? It's so true that patients often have to wait months to see a specialist and then get the ball rolling on a diagnosis, but that ball could start rolling right at the primary care level. So that's indeed very, very game changing. Yeah, indeed. And so in terms of Dr. Travaglia, you also mentioned treatment and starting treatment earlier. I'd like to talk about novel treatments. And so what does this mean for drug development for Alzheimer's? And how could these tests, I'm saying game-changing a lot, but how could they be game-changing in terms of clinical trials, enrolling patients, and identifying and stratifying patients for clinical trials?
Yeah, pharmaceutical companies and biotechs are desperately looking for the right patient at the right time. And so let's look at how clinical trials were done 20 years ago. It was just patients with a suspect Alzheimer's disease because there was no biomarker. And then at the end of the trial, as an endpoint, we were just looking at cognitive endpoints. And so we were guessing not once, but twice, whether we are having the right patients and whether the drug was going to be successful. Whereas now we are enhancing tremendously the drug development process because we are selecting the right patients, having these reliable biomarkers, and then we are tracking the way patients are doing with a specific drug. And ultimately, we're seeing whether the drug is going to be successful or not. And so this is changing the way trials are done, is enhancing drug development, and ultimately is improving the chance that the drug is going to be approved.
And I know, Dr. Schindler, you mentioned about how some of the tests are FDA approved and cleared, but some of them are not. And so what are sort of the regulatory hurdles and considerations that some of these tests need to overcome before they can be used in routine clinical practice across the board?
So this is actually complicated. None of these blood tests are yet FDA approved, but some of them are currently being considered by the FDA for approval. Keep in mind that these blood tests have really developed very rapidly. And while there's now quite a large volume of data showing their accuracy, that it takes a while to make your way through the regulatory process, we're hoping that this happens quickly. But right now, these blood tests are available through what we call a laboratory-developed test mechanism. And actually, there's many clinically available tests that are laboratory-developed tests and are clinically available through this mechanism. And they have data showing that they meet certain standards and follow certain protocols. But the FDA approval really requires a large amount of additional data. And so these tests are working through their way through that process right now.
And could these tests or the learnings from the study be applied to other neurological conditions? apart from, obviously, in addition to Alzheimer's? Depending on the biomarkers, of course, and things like that.
Absolutely. And I actually think that all these tests are helping to break the silos. Let me clarify what I mean with that. We're going to have more frequent monitoring because we need just a blood test and not a PET scan or a CSF analysis. And ultimately, we need to know whether there are pathophysiological changes in the brain. And it's not the disease that we're curing. It's not Parkinson, it's not ALS, it's not Alzheimer, but it's the mechanisms and the biomarkers that these conditions have in common. I'll give you a specific example. We at the FNIH recently launched a project in Parkinson's disease called MPDRD, Parkinson's disease and related disorders. And within this project, we are going to measure biomarkers typically linked to Alzheimer's disease, the p-tau and ratio of A-beta that we mentioned before in Parkinson patients. So it's not the biomarker per se, but that is related to a disease versus another, but it's in common to the pathophysiology that this disease have.
And just to add to that a little bit, I would say that the technologies that we're using to measure these biomarkers didn't really exist even a few years ago. And we've learned how to develop and use these technologies for Alzheimer's disease. And now I know that these groups are applying these same technologies. So some of the Simoa technology, immunoprecipitation mass spectrometry technology that we use for these specific blood tests, we're now using these technologies and applying them to other diseases as well. So I think everything that we've learned to develop biomarkers for Alzheimer's disease is going to be useful in developing biomarkers for all of these other neurodegenerative diseases.
And how do you see the landscape of Alzheimer's diagnosis through to treatment, drug development really evolving in the next couple of years? I think we've come a long way, of course, with these, with the blood-based biomarker tests. And so how do you see their application evolving and changing, the landscape of Alzheimer's disease?
Yeah, I mentioned before the evolution from clinical setting analysis to PET and CSF to this blood test. Now, in the next few years, I would say 1 to 5, we're going to see a widespread use of this blood test in the clinical practice. And I think that within 5 to 10 years, we're going to start seeing more and more digital health technologies used for Alzheimer's disease and other dementias and other neurological conditions. Imagine that you talk on the phone and the phone is speaking your voice, for example, and the algorithm with the use of artificial intelligence or machine learning is going to be able to identify whether you have Alzheimer's or not, or the way you sleep with the watch or trackers that you have in your wrist that is able to identify whether you have a condition or not. So I would say that blood biomarker is really at the horizon. It's happening very soon. And then we're going to see more and more digital health technologies.
I also think that these biomarkers are really going to help us to develop better treatments. So as a clinician who unfortunately has diagnosed people with these disorders and watched them decline over years without good treatments, I'm very hopeful that I'm not only going to diagnose patients, but actually be able to help them. And so I think these biomarkers will enable us to identify individuals early in the course of disease and start them on treatments so that they don't decline or don't decline as rapidly. And I'm hopeful that they will be very useful in clinical trials and that they will speed the development of effective therapies. And hopefully a few years from now, we'll have many treatments available. And hopefully we'll get to a point where we can use biomarkers to help us to figure out which treatments to use when. For some of these treatments, we may use them for a certain period of time and then stop them. So I think that there's just so many possibilities. It's really exciting.
And Dr. Travaglia, Dr. Schindler, thank you so much for leading the work that you are leading and for really making, all of your contributions in all of these exciting developments in the field. So thank you so much for the work that you do.
Thank you.
And thank you for being on the show today. Really appreciate your time and your insights and for sharing the results of this great study. And we look forward to seeing the real world application of these tests and to really help improve the patient experience and to help aid in the diagnosis and treatment of this disease. So thank you so much.
Thank you.
Thank you.
That's the end of this episode of the Xtalks Life Science Podcast. If you liked today's show, don't forget to rate, review, and subscribe. Thank you, everyone, and we will see you next week. Bye for now.
To join the Xtalks community, visit xtalks.com and register for exclusive access to curated content like live webinars, news articles, and educational videos. The views and opinions expressed in this podcast are those of the speakers sharing them and should not be taken as professional advice, nor do they necessarily reflect the policy or position of Honeycomb Worldwide. For further information, email us at podcast@xtalks.com.